Today's discussion is going to be on postpartum mental health. So, understanding the module of postnatal care, we need to know a bit about postpartum hemorrhage, the prevention and management, about postnatal care. The mental health plays a very, very vital role both in the antenatal and in the postnatal period. A bit about postpartum psychosis, sepsis during and after pregnancy, and the bacterial sepsis is given importance. And not to forget, assessing the neonate and understanding the basic neonatal problems. The key points not to forget in this particular module is not to miss the important guidelines that play a very, very crucial role, and also to follow particular algorithms for the management of postpartum hemorrhage, the mental health, and also for sepsis. As we know that all these three conditions can present as obstetric emergencies, it is vital for us to understand the step-by-step approach to all these conditions. It's very, very vital to differentiate the various disorders, especially in the mental health. So, know the buzzwords or the keywords to pick up, which is going to help us realize the differences between these disorders. And whenever you're doing an EMQ, try to apply the cover test for you to get the apt answer. Perinatal mental health, the guideline which covers the perinatal mental health makes some recommendation for the recognition, assessment, care and treatment of mental health problem in women during pregnancy and also in the postnatal period, which is seen up to 1 year after childbirth and in women who are planning pregnancy. Depression and anxiety, these two conditions are considered as the most common mental health problem during pregnancy. The percentage of women experiencing them are almost 12% with depression and 13% with anxiety. In the postpartum period, the condition is seen in almost 15 to 20% of women. Looking at postpartum psychosis, though it is very rare, with an incidence of 1 to 2 in 1,000 women who have given birth, but yet to remember that this is a very, very serious condition and is considered as an emergency. How do we go and assess these women and make the care plan? We need to start with the history of any mental health problems, look at what is her physical well-being, and also assess if there is any history of drug misuse or alcohol misuse. What is her attitude towards the pregnancy? Is she having any denial? Needs to be seen here. And any problems that is experienced by the women in any of her prior pregnancies needs to be addressed too. What is the mother-baby relationship like? And is there any past history of mental health problem for which she has taken treatment, or is she currently on any medications for treatment? What is her social network like? What is the quality of interpersonal relationship also needs to be addressed. Is she undergoing any social isolation? What is her family history like? Because any family history, especially a first degree relative with a mental health problem, poses her to a higher risk of developing a mental health problem in pregnancy and the postnatal period. Is she undergoing any domestic violence or abuse, or has she had any maltreatment in her childhood also needs to be seen here. We need to look at her economic status, her employment, and also her immigration status. The key points to always assess a mental health problem is to make the first encounter count. So, establishing a very good rapport with these women and also having neutral questions and open ended questions to assess the mental health is given prior importance. We need to have a therapeutic relationship before we start on with the treatment. To establish the risk factors, we need to ask specific and direct questions to the women, and an active communication and a teamwork is crucial for these kind of women. A recap of all psychiatric history and an examination needs to be recorded and documented well. And all the encounters needs to be therapeutic, and we have to optimize them in such a way. Start off with lifestyle support, and also if the woman is undergoing anxiety and low mood, that needs to be addressed right from the first encounter. Referrals need to be done appropriately, and direct referrals whenever needed need to be given to the women. Admission for mental health disorders depends on the severity of the women, and whether she has had prior admissions and prior treatment also needs to be looked into. Coming on to anxiety, regarding anxiety, we need to see the GAD-2 scale, which is the Generalized Anxiety Disorder Scale. In this scale, we address the women over her experiences for the past 2 weeks. How often she has been bothered by feeling nervous or anxious, and how often has she been bothered by not able to stop or control worry. This gives us a general idea about her anxiety problem in the last 2 weeks. If the woman is going to score 3 or more in the GAD-2 scale, then we use the GAD-7 scale for further assessment. Or we need to refer the women to a mental health professional for further assessment. If the woman is going to score less than 3 on the GAD-2 scale, but still if you're very concerned about her anxiety, then you need to have following questions also. And if we get a positive response, we again refer her or we use further assessment to evaluate her anxiety. Coming on to depression, we again have the questionnaire to assess her depression, and we are going to evaluate in the past 1 month how often she has been feeling down or depressed, and how often has she been having little interest or pleasure in doing things. Whenever we get a positive response to either of these questions, then we use the Edinburgh Postnatal Depression Scale or the Patient Health Questionnaire 9 as a part of this assessment. And whenever we suspect depression, we refer her to the mental health professional for further assessment. This is an example of the EPDS scale where the woman has got multiple questions which she need to answer. And based on the scoring she gets, she will be referred for further treatment and evaluation. So this is one scale which is commonly used worldwide for assessment of postnatal depression. When does a woman needs to be referred to a secondary mental health services? Whenever we are suspecting a woman to have very serious or severe mental illness, then referral is mandatory. If she has got any history in the past which is suggestive of a severe mental illness, let it be during pregnancy or at any other time, we need to refer her to secondary health services. Not to forget, if the woman is going to exhibit the symptoms of postpartum psychosis, then we'll have to give her an immediate referral to health services. Now, this referral, because of the condition of postpartum psychosis, needs to be started immediately, and the time period is usually 4 hours. What is the role of drugs in mental disorders? Choosing a drug for the women is usually done by a mental health professional. The important things to keep in mind, though there are multiple drugs available, we need to choose a drug with the lowest risk profile for the women and the fetus if the woman is in pregnancy or she is breastfeeding the baby. What was the women's previous responses to the medication also needs to be kept in mind. We need to use the lowest effective dose, especially if the woman is at risk of developing adverse effects. Whenever possible, use a single drug in preference to 2 or more drugs. And in pregnancy, we also need to remember that the dosages may need to be adjusted, and hence a woman who's already on drugs needs to be re-evaluated for making possible the woman is going to take the therapeutic doses. The most common drugs that are used are antipsychotics, lithium, benzodiazepines, and anticonvulsants. All these drugs pose specific risks in pregnancy and in the postpartum period. Antipsychotics are known to raise the prolactin levels, and hence the chance of developing gestational diabetes, weight gain are very, very common, especially with olanzapine, which has to be kept in mind. When the woman is on clozapine, her chances of developing agranulocytosis is quite high. Lithium is a very, very common drug that's used, and we need to remember a woman on lithium, there's a very high risk of her developing Epstein's anomaly and other fatal heart defects. If the woman is on lithium, then the plasma levels need to be monitored every 4 weeks and then weekly from the 36 weeks. Ensure that the birth is always in the hospital And in labor, we need to monitor the plasma lithium levels and the fluid balance need to be maintained because there's a severe risk of dehydration and lithium toxicity associated. Now, in labor, we have to stop the use of lithium and we need to check 12 hours after the last dose, the plasma lithium levels has to be monitored. If a woman is on benzodiazepines, then the risk of the baby developing cleft palate is quite high, and also floppy baby syndrome is commonly seen in the baby. Withdrawal of benzodiazepines need to be done very, very slowly. Other anticonvulsants like carbamazepine, the risk of the baby having a neural tube defect is seen in 6 per 10,000. And also, the other malformations that are associated with carbamazepine are GI and cardiac malformations. Use of lamotrigine is associated with oral cleft syndromes. Valproate again is associated with neural tube defects. So all these needs to be kept in mind and appropriately the antenatal care needs to be monitored for these women. The interventions for women with mental disorders going on to depression. If the woman is being diagnosed with mild to moderate depression, then we need to consider facilitated self-help for the women. However, severe depression or the women needs to be started on drugs. Moderate to severe depression, we also need to consider other psychological interventions like cognitive behavioral therapy. If the woman is already on medications, then we need to look at the safety profile of the medications and we need to see if we have to continue the medications or stop them or change to some other drugs. For anxiety, if the woman has got an anxiety disorder before pregnancy, then we have to refer her to the specialist or we need to give her therapy options. If the woman is not having any effect with the therapy, then we'll have to refer her to mental health professionals. Drugs, again, we have to decide based on the safety profile and based on the patient profile. Coming to psychosis always the woman has to be referred within 4 hours. She has to be evaluated by the specialist mental health professional. Admission in the mother baby unit and pharmacotherapy plays a vital role